Hey, we are going to talk about the pathophysiology of functional neurologic disorders today. What we know, what we don't know. Actually, there's a lot that we don't know, but I'm pretty jazzed about this topic because I am currently working on a chapter for a pathology book. And the chapter is on FND, which I have been immersed in a ton of research to prepare for this. So this might be a ton of information today because I have so much on my mind to share with you. But as usual, hit me up with some questions, send me a message. I got a couple of questions sent to me today that I want to answer for sure. So let's dive in. By the way, my name is Julie Hirschberg. I am a neurologic physical therapist. And I have a fan moving. It's really distracting in the background, but it is very hot at my house and there's not air conditioning. So I need this fan, but I'm sorry if it's very visually distracting. As I was saying, but I got distracted by that fan. My name is Julie Hirschberg. I'm a neurologic physical therapist. I am the owner and founder of Reactive Therapy and Wellness. And I am pretty obsessed with functional neurologic disorders. I love reading about it, learning about it. I love meeting people with it. And I was asked by one of my colleagues, also a professor, to write the chapter for a pathology book on FND. Now, I'm not a pathologist. I'm a physical therapist, but I have happened to teach for the last 12 years now, a neuropathology course at the University of Southern California for Doctor of Physical Therapy students. So this is my love. And so I've been working on this, finishing up. It's due at the end of the month, and been diving into a ton of literature in this area. So let's start with what exactly do we mean by pathophysiology? And even in the course that I teach, what is neuropathology? So neuropathology are understanding the disorders, the diseases of the nervous system. And when it comes to pathophysiology, that is really how does this disorder cause symptoms for a person? And it's different from etiology. So etiology is what is causing the disorder. And there's a lot of overlap between etiology and pathophysiology. So I might really be talking about both of those pieces. But I think what's important to know is in neurology in general, we don't always know why. We don't know the cause. We don't know some of the underlying mechanisms. This is true in many disorders, and there's a ton of research going on. So in Parkinson's, for example, we don't know exactly what causes it or why certain symptoms are occurring, and that's why they're doing tons of research. Same with multiple sclerosis, same with ALS, and many other neurologic disorders. We don't fully know and understand. So in many ways, a functional neurologic disorder is not different. So welcome to neuro. There's a lot of things we don't know. There's a lot of things that are complex. So that's the first thing that I want to say. When it comes to FND, we don't really need to be so weird about it. It is like other neurologic disorders in that there's some things that we just don't know. And also, like other neurologic disorders, there might be a history there. So, for example, I didn't really know this, but way back in the day, multiple sclerosis was called hysteria. And it was primarily, by the way, the original or thought of hysteria was that it was a wandering uterus in the body causing symptoms. So clearly we have grown and understand that MS is not hysteria. Very similar for FND. So functional neurologic disorders back in the day were also called hysteria. And again, this is in the 1800s where many ailments that women had were called hysteria. And not so. It's not a wandering uterus. And so that was kind of the original name given to things that, quite frankly, people just didn't understand. And so had to blame it on the uterus. And I'm kind of like tongue-in-cheek saying that, but actually that was very real and very unfortunate. So then as through history, FND has started to become better understood. So one of the earlier names for FND was also conversion disorder, which was a name really very popular in the realm of Freud and psychoanalytic, in that the physical symptoms were conversions or converted from psychological trauma or emotional distress. So that was a piece of the history of FND too, which leads to a lot of stigma. And it really wasn't until the modern era that, as people did research and studies, found out actually this was a lot more complicated than just saying it's psychological. And again, many things that were kind of misunderstood or hard to explain or outside of the realm of what we understand in the nervous system were often called psychological. So we've just gotten better, and we have better technology to understand this a little bit better. So enter the modern era, and here we are with functional neurologic disorders. And there's still a lot that we don't know. We do know they are not hysteria or just conversion disorder. We also know that they're not made up or faking. And this is, there was this really lovely study from 2009, which, by the way, I record this and I will put these studies, the full citation in the comments for this video. And I will send this out in our newsletter, which comes out on Friday for clinicians and Monday for patients. So back to this study. 2009, Cojan is the first author. They actually looked at fMRI, so functional magnetic resonance imaging, and they compared what faking weakness looked like on fMRI, compared that to functional weakness. Well, guess what? They look nothing the same. And so that is one thing that we do know, is that FND is not faking. We also know that it is not an entirely psychological disorder for every person. But I want to talk about this because somebody asked, let me pull up this question actually. They asked, what role does trauma play in FND? And while we have gone beyond conversion disorder or purely psychogenic, there has been recent research that shows that potentially there is a trauma subtype of functional neurologic disorder, meaning there's kind of, in many neurologic disorders, there's an umbrella of different types that you might have or different reasons that they might occur. For example, there's a genetic form of ALS, but not everybody has the genetic form. Well, just like in FND, there may be a trauma subtype. And there was this great article, which I want to share. Sorry about that. Also dropped my phone while I did that. But this particular article from the group at Mass General, and I believe this was from 2022, toward a possible trauma subtype of functional neurologic disorder, impact on symptom severity and physical health. And I won't go into the entire article, but essentially they looked at people with functional neurologic disorders and screened for the presence of a post-traumatic stress disorder, as well as the presence of adverse childhood life events, and found that there was a group of folks that had that fit those criteria. And it also predicted how severe the symptoms were and how severe their physical health was. Now, this is not unique to FND, by the way. There are other disorders in which if a person also has PTSD or extensive history of childhood trauma, they also have worse symptoms. So not unique to FND, but helpful for people to see and recognize that there might be a trauma subtype of FND. This is not everybody with FND. Not everybody with FND has had trauma or has PTSD or had adverse childhood events. But one of the pieces, so to get to the question about the role of trauma in FND, is there might be a role for that in some people. And also it makes sense because trauma changes the brain. It also even changes your genes, right? So there's epigenetic changes that can occur to genes with trauma. And in particular, in this study, I have like 100 studies up on my desktop here. So I'm going to see if I can pull it up quickly. They discuss some of the particular brain changes that occur. They have a very lovely discussion section on this. These correlate particularly with the control of movement. So here's where that pathophysiology, like why would the trauma changes in the brain cause abnormal movements? Like it doesn't really make sense to folks. And let me see if I could find this. Okay, so there's other neurobiological research. This is what the authors say. Gray matter. So they analyze gray matter and find that childhood maltreatment and adverse life events are linked to structural changes in the brain, in the insula, the amygdala, the hippocampus, the putamen, and the cerebellum. And get this, I found this so interesting too, that one study showed the magnitude of childhood physical abuse related to how closely coupled the amygdala and the insula were to the primary motor cortex. The primary motor cortex would be that part of your brain that would initiate movement. Actually, it's not the initiation, but it would create movement. The initiation comes before the primary motor cortex. But that's another discussion. So very interesting, right? So I think Julia asked me this question of how trauma might be related. It can be due to the brain changes. And again, this isn't for everybody. It seems to be a particular subgroup of people, but we cannot ignore that, right? The other thing is that those changes in the brain can also be reversed. And that's the power of therapy, right? I just wanted to go back here because I saw some comments come through. Cleveland Clinic diagnosed me with FND. They have no clue what's going on. MCAS from Lyme mold, COVID-19, Venom's vaccine injury. So I got to tell you, there is, thank you for that comment, because there are also interesting studies coming out linking functional neurologic disorders to other underlying events like a virus. Virus being some of the initial incident, physical injuries. This person also mentioned MCAS, mast cell activation syndrome. This is something that we also see a lot. Actually in people with FND or not FND, for example. But this is very important for clinicians to really understand that there are loads of other disorders that might coexist with a functional neurologic disorder, and those should also be treated. Just like in a trauma subtype, that also should be a part of treatment, and we should be looking at things and especially having a trauma-informed therapy for that person. But again, this is not everybody. So, but I wanted to answer that question. So I want to share one of our pie charts, which is the pathophysiology pie chart, which is really, this is how the pie chart was created, was us going through the literature, reading a lot of these studies and some of the underlying, that we're looking for underlying mechanisms to occur and categorizing those. So actually in each of these boxes are little one-line summaries of different studies that found motor control changes contributing to symptoms, sensory changes. This is a really big one. Psychosocial pieces. So those are some of the things that I just talked about. Lifestyle component, autonomic, and physical limitations. So all of these, so this is the very first pie chart, y'all. This is the original pie chart. All of these pieces coming together to inform what we know about potential mechanisms in FND. And I want to hit on a couple of things that we then know that are in these pieces of the pie. And by the way, because there are so many different types of functional neurologic disorders, these would be different for each person. Functional seizures and functional movement disorders, they often coexist. They might have some differences in underlying mechanisms. But we know, for example, that there are components of motor control, particularly in relation to attention, self-agency and autonomy, and the power of the brain to predict and create movement based on that prediction. All of those are motor control pieces. We also know from research that there might be sensory differences in a person's brain that could be contributing to the creation of functional neurologic disorder symptoms. Things like interoceptive differences, sensory processing differences. There was this very interesting study looking at sensory attenuation. So those pieces inform, and this is where I would tell you, probably if you're a person with FND, you have kind of recognized and understood that where you might fall on this pathophysiology pie. You might have understood that from the time you were born, you've had sensory processing differences than a lot of folks in the world. And this doesn't mean that we need to change your special brain. I'm a very firm believer in affirming some neurodiversity in our brains, neurodivergence. But we want to recognize and understand what your brain and your body might need and build tools for you. So this is why the pathophysiology is so important, because when we can understand what is underlying, what are the underlying mechanisms, we can get to treatment, right? So sensory pieces, psychosocial pieces that I already discussed, lifestyle, autonomic. So there's some interesting studies looking at the autonomic nervous system. And then physical injury is actually a really common trigger for functional neurologic disorder. But I think what you'll see here in this pie chart is it's complex. It's extremely complex. So I wanted to share from another study here. So let me see if I get the correct study. This one, love this. So, and actually this is not a study, this is a review that was published looking at a framework for understanding the pathophysiology of functional neurologic disorders. And this was, the lead author is Daniel Drain on this. And this is the study that has this lovely diagram that I really love, looking at a lot of these pieces. So I kind of think of this as a version of the pie chart. So one of the things that, even though I love the pie chart, that I don't love is that in the brain, in the nervous system, in the brain and the body, a lot of these pieces overlap. Those pieces of the pie. You really can't have a motor system without a sensory system, and so on. What I like about their figure here is they show those overlaps. So these are the areas that have been investigated and studied in FND, oftentimes with testing and fMRI, and found changes in some of those, the connectivity in particular areas under these constructs. So the construct of attention, of agency, of body awareness and interoception, of sensory motor function, of emotional dysregulation, of emotion processing, of salience, and all of these also really interacting at the middle with these brain mechanisms of prediction and inference as well. So I know that's a whole lot of words. And again, what I think that we see in each individual person, because each person is so different, is some of these kind of jump out in testing for us to really see, oh, this person's functional seizures may be really influenced by their lack of interoceptive awareness. And that's where we might intervene. So that one jumps out bigger. Ooh, great question. What is salience? So I think of salience in a couple of different ways. So salience, in just like the basic definition of the word is I'm finding it hard to find the words to describe it. So this is a very good question. What's important at the moment, right? So when I am running, my shoes and what I'm wearing are very salient and important to me. And in fact, I might even take note of what other people's shoes are because that's so salient to me. But salience in the brain is the brain does a lot of work behind the scenes to switch and choose. In fact, there's a whole network called the Salience Network to switch and choose what to pay attention to. So maybe that's even a better way to say it. That's why there's the overlap with attention. Is like, what should I attend to? Right? What's really salient to me and to this task? Now, I'll put this into context of a functional neurologic disorder. Oftentimes, after a person has an injury, I love to use the example of Oliver Sacks, really famous neurologist who had a knee injury, and what became very salient to him and what becomes salient to us after an injury is like attending to that limb. How's it doing? How's it moving? How does it feel? Does it bend this way? Does it not? What's the muscle doing? So that makes sense because we just had an injury, right? However, imagine how much brain space that really takes up. That's not exactly how the brain was designed to manage movement, was for us to consciously think and attend to every single muscle contraction and movement and all of those things, especially on a conscious level. And Sammy's saying, wow, I struggle with this. Yes. So we find, and they found in research, is that people with FND may struggle and I say they may struggle, but really it's your brain struggle to filter information, like it's all coming in and it's all full strength. So struggle with filtering that information and attending to what is most salient. It's hard to switch some things off and switch them on. So that's another piece that's really important. The salience network kind of acts as a switch in the brain. Anyway, what a great question. I had to talk about a little bit about the salience network. So, but I think what you can see here zooming out is that it's multiple factors that might be contributing to symptoms. So I want to go to one other question that someone sent me. And again, I think this was Julia as well. How come new symptoms arise at different times throughout your life in FND? What a brilliant question. Why does this happen? So I'm just going to stop sharing here. And again, this is complex, right? But everybody I have met with FND, every story I've heard has some variation of like, yeah, I had this, and then I developed this, and then I developed this, or then it switched to this went away, but then this happened, and so on. And why does that occur? And I don't have a black and white answer, is what I'll tell you. I wish I did, but neurology is not black and white. There's a lot of gray. But I would say it's multifactorial, right? So I might even bring the pie chart back up again here. So what we do know and understand with FND and the brain in general is that it is dependent on some environmental or social components. So, for example, I think of this, and I'm just going to use this because a lot of people kind of think of migraine and understand migraine this way, and I think FND is no different. But some days you have a migraine and you can't figure out why, and other days not. Or your migraine started at a particular time in your life, and you can't, there's no real clear rhyme or reason to that. And FND, similar, right? So it could be, and I'm just gonna to share many things that have been looked at or studied or I've heard clinically, could be related to hormones, could be related to atmospheric pressure. It could be related to what's happening in your life at the time. It could be related to sleep or the quality of your sleep. It could be related to a recent loss of a loved one or a stressful event. It could be related to the temperature outside. It could be related to the social pressures that a person feels developmentally. You know, they just went into junior high or high school, and it turns out actually they were autistic and they didn't know. But as the social pressures changed, some of these things became more apparent. And I use that example, by the way, because there have been studies done to look at the incidence of functional neurologic disorders with autism, and it seems to be a higher incidence with that. So with that in mind, it does. So here's what I want to say about fluctuating or changing symptoms. Sometimes we can figure that out. Sometimes we can see that it had a clear sensory component, or it had a clear motor control component, or maybe there was a particular lifestyle piece that changed. Or maybe it was little pieces of all of these that interact, and particularly they interact in the brain to change symptoms. And we don't always know. Now, I'm going to tell you, this is not different then multiple sclerosis. We don't always know why somebody might have an exacerbation of their symptoms in multiple sclerosis. In ALS, we don't always understand why one person's progresses in their arms and face and the other person's doesn't, why one progresses quickly and the other person doesn't. In Parkinson's disease, there's hundreds of variations of how it presents as well. We don't always really know why. And it's frustrating as heck, right? Like, it's so frustrating to not fully know and understand. But it's also not unique to functional neurologic disorders. Now, what is unique to functional neurologic disorders is that the symptoms can be variable or move body parts. These are things that are not seen in a disorder like multiple sclerosis or ALS or Parkinson's or stroke, where, one day it's weakness in the foot and the next day you're having tremor in the right arm. That is a unique feature to functional neurologic disorder. And that defies some of what we understand in the nervous system. But I tell you what it doesn't defy is this pie chart. It doesn't defy the understanding that we have with the connections between different areas in the brain and the role of some of those particular pieces that I showed in that other diagram of salience and attention and agency and so on. Those particular factors are why we might see this out of nowhere, or something changes very quickly, or boom, it's there one day, it's not there the next day. And that's due to those multiple brain factors. It's really multifactorial. And I think that is what's so important in understanding for FND, for if you have FND or if you're a clinician working with people with FND, it's very unlikely you're going to find one thing that is the cause. And same with other neurologic disorders. It's multifactorial. And just to summarize, based on what we talked about today, it can be many of these pieces of the pie. It could be, like we talked about, thank you for the great question, Julia. We talked about a trauma subtype of FND. But we talked also about the brain changes that can occur, which, by the way, you probably have heard this analogy of like it's a software problem and not a hardware problem. And I used that analogy a lot when I was first learning about FND as well. But I've really kind of let that analogy go because there are studies that show these distinct brain changes. Those are hardware things that are occurring. Now, they're not permanent necessarily hardware things. They're not irreversible hardware issues. But I just don't use that terminology. I don't think it's very helpful terminology to describe the pathophysiology of FND because there are some brain changes. Just like I don't think it's very helpful to use the term organic for other neurologic disorders and non-organic for FND because there are these brain changes and brain changes are organic. So bottom line, FND is multifactorial. It's also heterogeneous. So really no two people are very likely to have the same exact pathophysiology. We do know it's not in your head. It's not faked or made up. So studies have shown that. It's not entirely psychological, but we do understand there might be a trauma subtype, and that's important to treat, and that it's complex. It deserves an entire pie chart to look at underlying components of motor control, sensory, psychosocial components, lifestyle, autonomic, and physical limitations. So if you know what, if you're a physical therapist, I'm writing this chapter in a new version of the pathology book coming out. So stay tuned. I think it's pretty good. I'm pretty excited about the chapter of this book. And if you are a patient or clinician looking to learn more, join our newsletter. I write it every week. I send out the resources, so links to all of these articles. And if you comment newsletter, by the way, we'll send the link to sign up for the newsletter. I send it out to clinicians. You can join at reactiveeducation.com. I send it on Fridays, and then I send it to patients or family or other folks that are interested in listening or hearing and learning and just curious. I send you can sign up at reactivept.com, and I will send that out. But keep the great questions coming. Since I am finishing up this chapter, I had people vote on topics, and this was the top topic. But also people were interested in hearing about prognosis and other things. So I will keep chatting about these things, and I'll just share a summary of this chapter that I'm writing, because why not share it with you all. And by the way, if you are in our FND membership, we have a membership for people with FND. It's people all over the world. We do education classes, we do exercise classes, we do mind body classes together. We have an online community. It's amazing. I'm going to be talking about these things in that community too, in a little more depth. So I'm really excited about that, because I'm writing the chapter and I'm kind of like full in. So yeah, if you're in our FND membership, hold on tight. We're going to dive in. And if you're not, go check it out. Because this membership has just really been incredible for people with FND. So I see some comments here. I'm gonna make sure I get these comments because sometimes I don't see them after the live. And so I just wanna make sure I get them and get you the link to the newsletter. And I just wanna thank you so much. Thanks for being here. Thanks for sending questions. Continue to comment and send questions, and I will keep answering them. Thanks for being here. Thanks for being curious about the brain and all of these pieces, just like me. So have a good night, and I will see you next time.